Thank you. I'm Dan Catenacci, Associate Professor of Medicine at the University of Chicago and the Director of the GI Medical Oncology Program. I'll be talking about novel non-immunotherapy targets and agents in gastroesophageal adenocarcinoma. These are my disclosures. So this is the outline today, focusing first on HER2 amplification, then anti-angiogenesis, other genes with receptor tyrosine kinase amplification, and then claudin expression. As a background, we know we have a number of cytotoxic therapies available to us in various combinations and in various sequences. We also have a few targeted therapies and immunotherapies available today as listed in this table. We'll be focusing on the targeted therapies as opposed to immunotherapies. In the setting of best supportive care, what we see here is median overall survival plotted on the x-axis is around 3 months historically. And with various chemotherapeutic regimens, we can see here now that the median survival approaches just shy of 12 months. A preferred first-line regimen has emerged as FOLFOX. You can see landmark survivals that we would expect with all comers coming with these various therapies. HER2 gene amplification, we know occurs in about 10 to 15% of gastroesophageal adenocarcinoma. It's more higher incidence in proximal esophageal and G-junction adenocarcinoma, consistent with the higher incidence of CIN subgroup of the TCGA, or the chromosomal instability subgroup. You can see here the cell signaling pathway can be inhibited through a number of different mechanisms. Of course, Trastuzumab binding antibody to the extracellular domain, causing a number of factors, including internalization and degradation of the receptor, blocking signaling of cell signaling through the ligand, and also recruiting immune cells through the FC domain. We have Pertuzumab, which binds to a different region in the extracellular domain that inhibits heterodimerization with HER3. We have other novel agents like ZW25, which is a combination of these two epitopes in a bivalent antibody. We've got intracellular tyrosine kinase domain inhibitors, or TKIs, that are usually oral agents, and you can see a number listed here. And then we have antibody drug conjugate approaches, where usually on the backbone of Trastuzumab or on the backbone of ZW25, we have a conjugated cytotoxic agent. So the pivotal TOGA study, or Trastuzumab for the treatment of gastric cancer, now 10 years ago, showed an improvement in overall survival in the intention to treat subgroup and improvement in progression-free survival, as you can see here. We also learned from that study, though, you can see that the eligibility criteria were any FISH-positive tumor of irrespective of immunohistochemistry score, and any IHC3 plus tumor, even if it was FISH negative, which were a very small subgroup. But when you see this forest plot broken down by that, you can see that the majority of the patients were at least 2+ or higher expression and FISH positive. In an exploratory analysis, then looking at that subgroup, which is what we now define as HER2 positive, you can see the majority of the benefit was here, and you can see that therefore the survival benefit was more pronounced with a lower hazard ratio. And when you look at the really highly expressing tumors that are FISH positive, that's where the most pronounced benefit was realized. Now, superimposing those results from TOGA on our figure here, you can see that the original intention to treat group, the placebo arm, and then the Trastuzumab arm. But when you start to look at these higher yield subgroups, like what we now call HER2 positive tumors, approaches a median of 16 months. And if you look at the really high expressors, approaching 1.5 years. And remember, these are medians, and it's not uncommon for us to see patients living several years now with palliative therapy with HER2 targeted therapies, and you can see the improvements in these landmark survival times. In terms of testing, all of the groups and guidelines recommend still at this point to start with immunohistochemistry. If it's 3+, then it's considered positive. If it's 0 or 1+, it's considered negative. And only if it's 2+ or equivocal, then in situ hybridization or fluorescence in situ hybridization like FISH is recommended. and the cutoff there being a ratio of HER2 to the control probe of 2 or higher is considered positive. And I'll just note that the cutoff of cells is 10% or more of cells staining to be classified as in these groups. So there we have the TOGA study shown here with Trastuzumab showing improved survival, and this is looking at that subgroup within the study that was now what we call HER2 positive. So unfortunately, there have been a number of follow-up studies, phase 3 studies, in the first-line setting with the LOGIC and the JACOB study looking at lapatinib and the addition of pertuzumab, both of these studies being negative. And then we've had second-line studies, the TITAN and the GATSBY study with lapatinib and TDM1, also both negative. And so showing those curves here, you can see in the LOGIC study, the first-line lapatinib study, that it was negative. It did include patients that were 0 and 1 plus, and ultimately was a relatively smaller study, but it was negative. And then we see the JACOB study, which was the addition of pertuzumab to standard chemotherapy and trastuzumab, which trended to improvement, had a hazard ratio of 0.84, but not statistically significant. And so, you know, a nearly 800 patient study didn't have the power to detect such a small difference. We can sort of point to recent studies that have been much larger, like say Checkmate 649, which is double the size of this, where perhaps such a small value might have been identified even in the JACOB study if the study was large enough. So with respect to second-line studies, the TITAN and the GATSBY study were both negative studies, and what we've learned in the interim is that both of these studies, having allowed patients to be eligible based on their HER2 status at first diagnosis prior to first-line therapy, and that our understanding now that a common mechanism of resistance to first-line anti-HER2 based therapy is to select for HER2 negative clones. And so without re-examining tissue or blood to ensure that patients are still driven by HER2, their tumors, prior to enrollment in second-line therapy, many of the patients in both these studies were likely not dependent on HER2 and could contribute to a negative study. That said, even so, the response rate with lapatinib was 27% with paclitaxel compared to 9%, but it still didn't translate to a significant overall survival benefit. But when we look at patients who were IHC 3+ to begin with, prior to first-line therapy, there was an apparent survival advantage with a pretty significant hazard ratio. And although the response rate was not reported in this subgroup, you might imagine that it would be higher than even that 27% in all comers. Some other notes are, again, in the TITAN study did include IHC 0 and 1 plus tumors, which we now know are not sensitive to these anti-HER2 therapies. And in addition to that, what we do understand is that IHC 3+ or the highest level expressors are the ones less likely to evolve to become negative into later lines in second line, as opposed to IHC 2+ and FISH positive. So again, these patients were more likely to still be HER2 positive. So regardless, in second line, there are no standard anti-HER2 therapy approaches. And so when we look at say in comparison to the breast cancer space, where each of the relevant and equivalent studies were all positive, we only have one in the first-line setting and all the negative studies that followed afterwards. Again, one of the, especially in the second-line setting, one of the factors would be molecular heterogeneity. So putting this into context now into routine standard of care therapy, we really need to be thinking about molecular subgroups within the disease and focusing now on HER2 positive tumors to start with trastuzumab-based first-line therapy. Again, although the TOGA study had cisplatin as the backbone, many of us do use FOLFOX because of the ease, the better tolerability, and even suggestion that it's more effective. Yet there is no indication to continue this into later lines based on those studies I just showed you. That said, there are some promising phase 2 studies that have been reported in later lines. This is one of them in second line with the drug Margetuximab, which is an enhanced Trastuzumab molecule plus Pembrolizumab. So enhanced meaning that these anti-HER2 antibodies can bind based on binding to the epitope of HER2, but the back end FC domain can recruit NK cells and macrophages and immunomodulate the tumor microenvironment and cause antibody-dependent cell-mediated cytotoxicity, or ADCC. And that's in the backdrop of knowing that the receptor, the Fc gamma receptor 3 or CD16A, that's on the NK cells that binds to the Fc domain. In society, there are different alleles, V allele and F allele, that have different affinities for the Fc domain. And you can see 85% of people have at least one, if not two, low affinity alleles. And so the difference there in the Trastuzumab versus Margetuximab is that Margetuximab is enhanced to try and enhance this ADCC capability even in those lower affinity tumor groups. And then in addition to that, combining with a checkpoint inhibitor like Pembrolizumab study, the combination and working in concert, the innate immunity and the adaptive immunity working together to enhance tumor cell destruction. And so this study that was reported recently in Lancet Oncology enrolled 92 patients with an overall response rate of 18% in second line. Similar to those other second line studies, though, these patients were not confirmed to be HER2 positive just prior to starting second line therapy. It was based on their diagnostic pre-first line therapy treatment. But some things to note from this study were that of the responders, all of them were IHC3 plus prior to first-line therapy. 79% of them were PD-L1 positive prior to first-line therapy, and 88% of them had ctDNA positivity for HER2 amplification just prior to second-line therapy. So all factors that point to, if you select the right patient group, you'll really enhance the ability of these agents to work. And remember, this is with chemotherapy-free regimen. Also, if you looked at double positive, HER2 positive, and PD-L1 positive, you can enhance the response rate, and triple positive, meaning they were IHC3 plus at baseline, HER2 amplified just prior to second line, and PD-L1 just prior to first line, you can enhance the response rate. Again, these are smaller numbers now, we have to be cautious in subgroup analyses, but consistent with the hypothesis. And then looking at a secondary endpoint of the study, survival, you can see that, again, those that were double positive, IHC3 plus and PD-L1 positive prior to first-line therapy had the best outcome, 3 plus, but PD-L1 negative, 2 plus FISH positive, but PD-L1 positive, and then double negative, so to speak. You can see that it actually separates as one might expect based on these biomarkers. So based on that study, actually, this combination has been moved to earlier line therapy, and in a study called Mahogany, which is sort of a 2-module study. The module A is basically this chemo-free regimen approach with Margetuximab plus the company PD-1 inhibitor in highly selected, biomarker-selected patients that are 3 plus positive and PD-L1 positive by the CPS1 cutoff. And they're getting these dual antibody approach and then potentially proceeding if response rates are showing activity. And then the other module is based on a more classic design of any HER2 positive disease, irrespective of PD-L1, and then randomized to various options, standard of care versus Margetuximab in place of Trastuzumab versus Margetuximab plus a PD-1 inhibitor or plus a PD-1/LEG-3 bivalent antibody as a choose your winner strategy to go on to a phase 3 study. Another very interesting study that was reported and recently published in New England Journal is a third-line study with Trastuzumab Deruxtecan ADC, a 2-to-1 randomization in this setting, a completely Asian study. And you can see here the response rate was clearly better with Trastuzumab Deruxtecan versus physician's choice of chemo with taxane versus irinotecan monotherapy. And then you can see also the overall survival and the progression-free survival showing benefit in this randomized phase 2 study. Very promising and a welcome option, especially in the third line or higher setting. That said, there are some things to point out about this agent. It is a targeted therapy, and it's targeted towards HER2 with Trastuzumab backbone. However, you can see here the grade 3 and higher toxicities are actually higher than even the chemotherapy arm. So this does come with a cost, and one of the costs that we should really recognize is a pneumonitis that is associated with this agent up to 10% of patients, a quarter of which are grade 3-4. And so something that we need to recognize. And in other trials, like in the colon cancer trial, actually deaths due to pneumonitis. So that said, it is undergoing regulatory review in Japan. And here it's been submitted to the FDA for breakthrough therapy and orphan drug designation. We know it was also recently approved in breast cancer. There are also other follow-up studies, Destiny-Gastric2, which is a second-line Western population study, which will be important to compare to what was seen in that all-Asian study. In a single-arm study, all patients are required to confirm that they're positive for HER2 prior to enrollment to second line. And then there's a Destiny-Gastric3, which is an exploratory study looking at this agent with other chemotherapy or immunotherapies. And then a Destiny-Gastric4, a planned phase 3 randomized study in that second line setting. So again, moving this agent earlier, even into second line, knowing some of the toxicity risks, we'll really have to see and pay attention to the data of these studies in comparison to, say, standard paclitaxel ramucirumab, or in comparison even just to other HER2 therapies that don't cause this risk. Those such therapies are listed here, in addition to all of those other ones I had mentioned earlier, like Pertuzumab, TDM1, and Lapatinib. There are a number of others that are coming through, like ZW25, ZW49, which is an ADC built on top of ZW25, Tucatinib, a novel tyrosine kinase inhibitor, often being tested in combination with Trastuzumab, referred to as vertical inhibition, extracellular and intracellularly, and then other sort of novel agents earlier in development, like by this bispecific construct against HER2 and other immunomodulatory markers. One slide on the perioperative setting for HER2 therapy. This was what I used to show, is that basically there's very little data, partly because it's very difficult to study any perioperative study. But in addition to that, now we're limiting to 10 to 15% of patients that are HER2 positive. And so we had the HER-FLOT study, a small phase 2 single-arm study that's still an abstract form from several years ago with an interesting pathologic response rate. And we had combination study with Lapatinib and ECX just for safety, no efficacy reported. And then we had a really small sample set amongst our FOLFIRI-Ram study, but again showing similar grade 1 responses when combining Trastuzumab to chemo. And then I would always point to other larger studies that were ongoing, but now we do have a few that just read out recently at ASCO. Unfortunately, the Petrarca study, which was a planned phase 2-3 study, terminated early, even before completing the phase 2 part, due to the negative Jacob study, and the study sponsor terminated this Petrarca study. And then the RTOG study, technically a phase 3 study, but less than 200 patients, and a function of the fact that it's hard to run a study with 10 to 15% of the population in perioperative setting, and still took 10 years to accrue this small sample size, relatively. That said, we do see the RTA-1010 was a negative study for disease-free survival and overall survival, looking at a really large target hazard ratio, so potentially not enough power to detect a more likely hazard ratio, unfortunately. No difference in pathologic response rate. In the Petrarca study, of those patients enrolled and randomized, you can see, though, that the pathologic response rate was higher, the complete response rate with the dual antibody compared to the chemo, and also trended to higher with disease-free survival and overall survival. So it's unfortunate to see in a larger sample set if this actually could help improve cure rates in these patients. Moving on then to anti-angiogenesis, we know there are, again, a number of different mechanisms of inhibiting this pathway, from ligand blocking to receptor blocking to internal tyrosine kinase inhibitors. Unfortunately, in the first line setting, there have been a slew of studies that have been technically negative. The ones boxed out are the big phase 3 studies with bevacizumab and ramucirumab, both having higher response rates, both having higher progression-free survival rates, trending to overall survival benefits, but not statistically significant. So not a standard of care in the first-line setting. In the second-line setting, however, there have been 2 randomized phase 3 studies regarding Rainbow with ramucirumab, either alone or in combination, showing a consistent benefit hazard ratio of 0.8, a modest benefit, but a real benefit, and a standard of care in that second-line setting. Some TKIs have shown benefit in late line, like apatinib in this all-Chinese study, but then after changing the name and repeating in a more global study, recently reportedly negative. So certainly not a standard option for us here. Along these lines in the second-line setting with anti-angiogenesis, now with FLOT and CROSS being standard options in the perioperative setting, what do we do in patients who recur quickly? Unfortunately, there are still those patients who recur within 6 months who we might consider these regimens more like a first-line approach that have failed. And with taxane and platinum already failed, what would we do in that second-line setting? It doesn't make a lot of sense to give more paclitaxel plus ramucirumab, in other words. And so in those specific indications, potentially using FOLFIRI, which we already know in the first-line setting is effective compared to, say, ECX in the French study, but certainly in the second-line setting. And in other situations as well, where there's a precluding neuropathy from prior therapies, where you want to avoid more neurotoxic agents and switch to a non-neurotoxic regimen, and also other convenience factors like every other week dosing versus weekly dosing, things like this. And in this retrospective report that we grouped together with a couple of different centers, we showed outcomes that would be very similar to what we would see with the Rainbow. So the claim is not that it's better, it's just that it's maybe more tolerated and more logical in certain situations. And of course, we have a category 1 indication in the NCCN guidelines for PAC-RAM, but it now is in there under these certain circumstances that you could consider FOLFIRI based on our report. And you can see here, I had mentioned in the earlier slide that we like to not do the bolus or ban the bolus or hold the Mayo. But it is listed here to consider it. But in my opinion, that just adds toxicity and really doesn't add much in terms of efficacy. Then most recently in ASCO, we have the Ramirez study, which was a randomized study, phase 2 study, comparing these regimens, FOLFIRI-Ram and paclitaxel-Ram, and you can see there's no real differences in the intention to treat. Overall survival maybe trending towards FOLFIRI in the PFS, and then certainly in the pre-treated taxane group, you can see that that's maybe a little bit more pronounced. And the response rates are similar, if anything, pointing towards a little bit better with FOLFIRI and ramucirumab, particularly in those previously treated with taxane. So something to remember for second line. Also, for anti-angiogenesis, just to round it out, of course, adding immunotherapy could be of interest here, both with antibodies, but also with tyrosine kinase inhibitors, even more so. In these smaller phase 2 studies, you can see some pretty interesting response rates. So it'll be important for us to do this in a larger, more controlled setting. And these are very promising strategies that we look forward to those results. Looking to the next segment, receptor tyrosine kinase amplifications, just as background, we know that EGFR inhibitors with cetuximab, panitumumab, and gefitinib in first line and second line expand REAL3 and COG studies were all negative in the intention to treat analysis, which was in all comers. But as you know, my motto is targeted therapies for targeted populations. And when you look at these subgroups within these studies, like the COG study, those that were amplified, although small, about 5%, which is exactly where you would expect it to be, you can see that there's an improvement in overall survival favoring gefitinib. Similarly with the EXPAND study by immunohistochemistry, where we know that EGFR amplification leads to overexpression of EGFR, that those at the highest levels by H-score are the ones that are deriving benefit by PFS and OS. And these patients, again, were about 5% of the population, exactly those patients that we would anticipate would be EGFR amplified tumors. So we also reported this in a retrospective prospective analysis, looking in our sample set of metastatic patients, finding an EGFR amplification rate of about 6%, also looking in the Foundation 1 database at the time, again showing about a 6% incidence rate, and patients exposed to various regimens with EGFR therapies showing a waterfall plot here with a nice response rate, even in monotherapy cetuximab in late line with a pretty long duration that you can see this patient having a complete response lasting more than 1 year. So in the right patient, I think that could be an option, but the problem has been, again, it's a really relatively low incidence population, very hard to study, very hard to move that needle forward to become a routine option for patients. So that EGFR story is very akin to MET amplification story, where we've had negative phase 3 studies with Rilotumumab and with Onartuzumab, both ligand-blocking antibodies, but not necessarily specific inhibitors for MET amplification. And so the difference there, of course, is that Rilotumumab, which binds to the ligand itself, Onartuzumab binding to the receptor but blocking the ligand, but not causing receptor internalization, ADCC, or any of the other factors that, say, Trastuzumab and other molecules can cause. These would not be effective in inhibiting MET amplification. So that said, we do have MET inhibitors like tyrosine kinase inhibitors, which would be very effective in MET amplification in preclinical models. And in this particular study, probably the largest looking at this question, looked at 45 patients with gastroesophageal cancer with MET amplification, which occurs in about 5% of the disease, where you can see in late line disease predominantly, the response rates were pretty impressive, 18%, median duration of response 6 months, median overall survival 8 months, and many of these curves looking a lot like immunotherapy curves. But at the same time, this study was closed because it was deemed ineffective and too small of a subset overall to proceed. And then finally, a very similar study, yet again, is with FGFR2 gene amplification, again about 5% of the population, where we just reported with a monoclonal antibody to FGFR2 that does cause ADCC, a response rate in 18% of patients and disease control rate of 64% of patients, and with some with pretty good duration of response. And this has led to a phase 3 study in the first line setting in combination with chemotherapy as opposed to monotherapy like here in the late line, with the intention to try and treat patients as soon as possible. This study was recently downgraded to a phase 2 randomized study, again, due to the challenges of selecting that biomarker being relatively rare. Then finally, we'll talk about the Claudin story. So Claudin 18.2 is a member of the Claudin family that's involved in tight junctions, and it's broadly expressed in many cancer types, including most of gastric cancers. It's not expressed on normal healthy tissues other than gastric mucosa. Normal gastric mucosa does express it. And a monoclonal antibody originally known as IMAB362, then changed to Claudiximab, and then changed hands and was changed to Zolbetuximab, is highly specific for this receptor protein. And modes of action are thought to be, again, through ADCC and also CDC, and in combination with chemotherapy can help to immunomodulate the microenvironment. So this study that was done with this antibody called the FAST randomized phase 2 study done in Europe, you can see had an improvement in progression-free survival and overall survival in the intention to treat analysis, which was in patients selected by expressing this protein at least by 2+ in at least 40% of cells. There was a pre-planned subgroup analysis to look at the higher level of expression, more cells expressing this same intensity. And you can see that the hazard ratios are even more pronounced than in those selected by 40%. So that led to the prospective phase 3 study of Spotlight with chemo plus or minus Zolbetuximab, placebo-controlled, and also a more predominant Asian study with Capox backbone called GLOW. So we look forward to the results of that study as well. So to summarize, we talked about HER2 gene amplification. We know it's a first-line standard to add trastuzumab to chemo. Unfortunately, other studies with other agents have failed in first and later line setting for various reasons we talked about. Another main one is molecular heterogeneity. The perioperative setting has been elusive. Many new promising agents that we talked about, and potentially in combination with immuno-oncology anti-PD-1 inhibitors. Anti-angiogenesis is a standard option in the second-line setting. Unfortunately, it's failed in the first-line setting, and they didn't mention a perioperative study of FLOT with or without ramucirumab called RAMSES, which showed some promising outcomes at a randomized phase 2 component at ASCO this year, and it's ongoing as a phase 3 study. And again, combinations of anti-angiogenesis with immuno-oncologic agents is an area of interest, particularly TKIs. And then finally, receptor tyrosine kinase amplification. We talked about EGFR, MET, and FGFR2 in addition to HER2, all in that CIN subgroup, all about 5% to 7% incidence each, all with supportive preclinical and phase 2 data, but elusive in terms of moving this forward to getting these options to our patients. Again, there's possibilities of combining these with immunotherapy as well. And then there's the Claudin story, which is based on the randomized phase 2 FAST study with zolbetuximab, with now 2 large phase 3 studies ongoing that we look forward to the options. And again, there is the possibility of combining this agent with other checkpoint inhibitors to enhance the immunomodulatory response. So I'll stop there, and I thank you for your attention.